Superintendent, DD Medical College and Hospital, to brief the gathering with few words.
Respected Chief Guest of the occasion, Member of Parliament, Keynote, Sujukta Naik sir, Dean Madam, Founder, Heartmate team, colleagues, my dear students. This is my proud privilege to welcome this auspicious gathering to the Ecg Symposium. So I felt very happy we are with us our Member of Parliament Anta sir, and we have also discussed regarding the issues, and this is the very good platform because that we meet here. We have discussed vividly regarding the issues related to the teaching and medical college. So I am most thankful to MP sir. He has given the assurance, the man of the soils, and we are also getting Honorable Chief Minister this soil, and we are happy to these moments, and we are very much proud this evening. So he has given the all assurance to make a new medical college to the full medical college within no times. So in this regards, I also thanks all our healthy livings. He has also given assurance to the students, and in this beautiful moments, again I thanks to our member chief guest of the occasions, and students, colleagues, and the media persons. Definitely who will help us to achieve the goal, and we have a great day today and for the future. Thank you. Thank you.
Thank you, sir. Thank you for inspiring us all and to learn more and more. Now I would request Dr. Chinmayi Mohapatra, Dean, DD Medical College and Hospital, to please come onto the dais and address the gathering.
Good evening to all. Respected MP sir, Sujukta Naik, other dignitaries on the dais, and invited other persons, the media people, and my dear students. Today is a hectic day for all of us, but we are all enjoying it because in the morning we had a CME on non-communicable diseases. It was presented by our faculties. Then our students very nicely they have presented many posters and all the answers to the questions asked by the judges as the part of Pharmacovigilance Week. Then this is the third event of today. where our honorable MP sir, he has come to inaugurate our another workshop on ECG, which is a very, very important event for all the students. So before when we met MP sir, actually me, myself and Superintendent sir, we have discussed with him. As we are trying from the very beginning of the college, how to improve this college, day and night, our thinking, always we are thinking about the growth and development of this college. But we are not at all satisfied because it is very slow pace it is going. So that only we have ventilated to our MP sir. Our students also, they met and they have also ventilated their problems here. How we are trying so many times for a particular event to be to make it a successful. How many times we are trying, but till today we are not got many of the demands of the student fulfilled, though they are all genuine demands. We feel that they are genuine demands. But where is the fault, we don't know, we are trying. So we have discussed with sir that we are, all of us, our students and all the faculties, we are trying our best to improve, to develop this college, which is the first of this kind in Keonjhar district, which was initiated from so many years back. Sir was also a part of that. So sir assured us that you write down all your problems from the academic side, also from the hospital side, and he will try to solve this in a particular forum. He will ask and try to solve this. That gave us that assurance. We got. We are very grateful to him, and we hope all our demands in the proper way it will be fulfilled, because now MP and the Chief Minister, they are all from our district. So we expect a lot. This is natural that we will expect, and we hope it will be fulfilled. So let us today, after the deliberation or the speech from our chief guest and other dignitaries, we will again learn about the very important topic, that is the ECG. That's all. Thank you.
Thank you, ma'am. Thank you for putting up all, summarizing the students' concerns and the way we have put it to MP sir. We are hopeful that things will be better in future. Thank you, ma'am. Now, without much ado, I would introduce our chief guest of this hour, Shri Ananta Naik. He has been over 23 years of active political involvement, focusing on Keonjhar, Mayurbhanj and Jajpur districts, with specific attention to organizing political programs, building connections to improvise Dalit youth and senior citizens. His key political positions which are held was 13th Lok Sabha member, represented Keonjhar in 2 consecutive terms, 14th Lok Sabha member from 2004 to 2009, re-elected as a representative from Keonjhar, held several key positions including member of the Standing Committee on Industry and Labour, Ministry of Steel, Ministry of HRD and Railways, District President of BJP Keonjhar from 2001 to 2003 and 2012 to 2015, All India President of BJP ST Morcha from 2006 to 2009. Social profile, he is various involvement as a Vice President of All India Gond Mahasabha, President of SN Mahavidyalaya, Chairperson of Lok Sanskriti Trust, and former President of Keonjhar District Football Association and ex-President of Kalinga Iron Work Labour Union. Shri Ananta Naik ji has been instrumental in promoting tribal welfare, social causes and development initiatives in Odisha, especially Keonjhar. He has also worked in the fields of environment protection, traditional sports and indigenous culture propagation. Sir, with this brief introduction, we would request you to have interaction with our students and deliver your keynote's message to them. Welcome on the dais, sir.
हार्टमेट रो प्रतिष्ठाता ऋषिकांत महांतर वो जो नोबल काम समाज में तार परिप्रेक्षी एठी आजिका जो सभा उपस्थित आपण मान मैडम महापात्र सुपरिटेडेंट नायक बाबू मोर बंधु डॉक्टर महेश जो क्लासमेट बंधु रूममेट कॉलेज स्टूडेंट कॉलेज डीडी कॉलेज स्वाई बाबू धानी बाबू एवं उपस्थित मैडम छात्र भाई बोल मेडिकल रो मो स्टूडेंट नुहे आप सब मेडिकल स्टूडेंट जस्ट एमपी पूर्व ट्राइबल कमिशन वाइस प्रेसिडेंट से आम ऑल इंडिया लेवल रे एजुकेशन सिस्टम इन ट्राइबल एरिया गोटे सेमिनार कर आम जो डॉक्टर मान भी डाकी स्टेट गवर्नमेंट सेंट्रल गवर्नमेंट कन्सर्न ऑफिसर मान भी डाकी गोटे डिस्कशन ओपन डिस्कशन है जे ग्राउंड रे एते सुविधा हला पर भी पर्टिकुलर केंजोल एरिया ट्राइबल एरिया रे लोक मानकर मेडिकल रो सुविधा केते नेउछते कमी कोठी बढ़िया इंटरेस्टिंग सब ग्राउंड रो गाँ लोक मान पाखु आसे स्वाभाविक आसवा पर मोर मन पड़े प्राइम मिनिस्टर जो कहते अनेक समय जे अतीतर आमर जो ज्ञान सहित वर्तमान ज्ञान को मिसेक आम क्या अच्छे आम अतीतर ज्ञान टाक नहीं आगे गले भी वर्ल्ड जो लेवल पहुँचे आम पहुँची पारानी किंतु अतीतर ज्ञान को छाड़ीदे भी आम बाट हुड़ी जा तेणु अतीतर ज्ञान सहित वर्तमान ज्ञान को मिसेकरी केते स्पीडी रे आगू जा लोक मान ऑल वर्ल्ड लेवल रे आमर लोक मान से सुविधा दे पार ये माननीय प्रधानमंत्री सोच हेल्थ क्षेत्र में भी से भाया आसवा पर मु किसी बही पढ़ुली प्रधानमंत्री जो कहते विश्वगुरु बनैबा विश्वगुरु बनैबा तो हेल्थ रे सब कहते डॉक्टर कोड पढ़ी आसी अमेरिका पढ़ी आसी डॉक्टर कोड पढ़ी आसी इंग्लैंड पढ़ी आसी मेसीन कोड आसी जर्मन रू मेसीन आसी कॉन्सेप्ट माइंडसेट जे भारत अपेक्षा हेल्थ रे अधिका उन्नत धरण फॉरेन रे अच्छी ये माइंडसेट जदि अधिका उन्नत धरण थिला ताहले कोविड बेले तो अमेरिका रे जर्मन रे जी मरले से तुलना भारत रो जदि परसेंट देखा आम बहुत कम तार मीनिंग है हेल्थ सिस्टम रे मध्य आमर अतीतर जो सिस्टम टा अछि से सिस्टम भीतर आमर वर्तमान कमी कोनटा अछि जोथि पय आमे सामना को देखै पाना थी ताको देखैबा कथा मोर माइंड में जोटा अच्छी मो आमे गोटे पढ़ु सुमुद्री जनकर बौद्धिक समीर महांती आम आरएसएस पूर्व प्रांतर सभापति मुझे दिन जड़का भाई अनेक रही सब हार्ट डिजीज कौन पाई हुए कैंसर कौन पाई हुए तुम ब्लड प्रेशर कौन पाई हुए को ग्रंथिटा को कौन कमिले इटा हुए माने प्रमाण सहित प्रमाण संगत वेदरु प्रमाण संगत बतौले मुझे खोजिली कौ जगह पर कथा ही पारे सीटा मुझे देखुली आम रोगटा कौन पाई होची आम एबे जो पेसेंट आम आसुक पेसेंट आसला माने आमर माइंडसेट है गोटे अंग आसला पेसेंट आसला माने गोटे अंग आसला कैंसर पेसेंट आसला माने कैंसर जो जगह अच्छी पर्टिकुलर से जगह गोटे अंगटा आसला गोड़टा भांगी पेसेंट आसी गोड़टा भांगी जोटा से अंगटा आसला किंतु आमर कनसेप्टा
अतीतर जो आम ट्रिटमेंट पद्धति आम अंगटा ट्रिटमेंट करती आम मनुष्यटा ट्रिटमेंट करती तो मनुष्यटा जो ट्रिटमेंट कर मनुष्य ये टोटाल मनुष्यटा ट्रिटमेंट कर डॉक्टर तो हार्ट डॉक्टर हार्ट ट्रिटमेंट कर तुम स्किन डॉक्टर स्किन ट्रिटमेंट कर तो ताले टोटाल मनुष्यर ट्रिटमेंटा तो केमती एपट आस टोटाल मनुष्यर ट्रिटमेंट होगा दरकार निर्दिष्ट गोटे जगह ट्रिटमेंट है भल हो नहीं आज किसी भले जो पुणी हुए तो आउ थे आसपे सीटा मुझे देखुली गोटे जगह क्लीयर आमर सुश्रुत संहिता वेदरे मेंशन कर देछि ऋग वेदरे जे रोगटा जो आसी रोगटा मनरु आसी कहीं आमर बात पित्त कफ आपण मैंने बुझे तीन टाइम स्टेबल रहा किसी रोग नहीं लोकटा नर्माल बात पित्त कफ तीन टाइम बॉडी में नर्माल रहा किसी रोग हम नहीं लास्ट 100 वर्ष अधिका बचे तो बात पित्त कफ तीन टा अनबालांस हेले रोग आस बात पित्त तीन टा अनबालांस केतबेले आसीबो बात पित्त तीन टा अनबालांस आसीबो जेतेबेले तार स्नायु रे अनबालांस आसीबो तार स्नायु रे अनबालांस केतबेले आसीबो जेतेबेले तार श्वास रे अनबालांस आसीबो तार श्वास रे अनबालांस केतबेले आसीबो जेतेबेले तार प्राण रे अनबालांस आसीबो तार प्राणटा अनबालांस केतबेले आसीबो जेतो तार मनटा अनबालांस तेणु मनटा अनबालांस होकर आसिकी तापर जाके रोगी को आप कहते रोग हो गला रोगी जन आस तेणु ट्रिटमेंट आमर भारतीय पद्धति ट्रिटमेंट है टोटाली ओभरऑल ट्रिटमेंट आम गोटे गोटे जगार रोगटा शीघ्र भल जाए देखिए से डॉक्टर पाक गले एत कणई कथा कहे स्नेह भरे कथा कहे जे तो छुआ को देखले कौन कर तो बापा कि कर तुम कौन जमी कि फसल होती से डॉक्टर ये मधुर कथा शुणिक से पेसेंटा रोगटा कौन कौन आसी साइकोलोजिकाली से भूली सारी आ तार श्रद्धा डॉक्टर श्रद्धा रे जो रोग ये मेडिसिन देव सीटा भल हो मोर सांग गोटे एम्स रे अच्छी मुझे पचारूली कथा होता सी कहला कोविड समय मैटर नहीं करी कोविड बहुत लोक मले कथा कहला आम गोटे परीक्षा करते गोटे लोक को गोटे घर भितर भर्ती कर दिया ये मरवा को डॉक्टर मान जानले ये मरवा जाऊँगी ट्रिटमेंट अनुसार आ बेसी समय बचबनी से समय गोटे लोकटा को से गोटे घर भितर भर्ती कर गोटे सापटा को छाड़दे आ घंटे पर डॉक्टर मान तो राइट टाइम कहते लोक भाई आ घंटे बचो लोक घंटे पर मरी जाओ मृत्यु होकार जो डॉक्टर मान के कैलकुलेशन तार मृत्यु पर पोस्टमार्टम करागला पोस्टमार्टम देखागला विष जाला सी मरी साप दर्शन करें किंतु विष ज्वाला सी मरी तार बॉडी रू विष मिलला कौन पाई ना सामना जो सापटा को देखला काड़ी सापटा मत मारदेव एना मु मरीजी सापटा मत मारदेव मुई ना मरीजी मत विष घारीज ये मत घर भितर अच्छी तार माइंड रे मन भितर जो साइकोलोजी चलना ना साइकोलोजी बढ़ी 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 तार हिसाब से विष तैयारी होगला आ से विषटा सी मरीगला ये सत्य आधारित गप मु कहूनी तेणु जो प्रथम मु जो मन कथा आसेनी ये ट्रिटमेंट से आधार हो ट्राइबाल जो ट्रिटमेंट आप ट्राइबाल बेल्ट अच्छा ट्राइबाल बेल्ट जो ट्रिटमेंट हुए ट्राइबाल ताकू जहाँ रोग हेल्ले भी सी आसोनी कौन पर आसोनी तार क्यारेक्टरटा गोटे अच्छे जो क्यारेक्टरटा ट्राइबाल कहुच्छे आदिवासी कहते से क्यारेक्टर है साइलेस क्यारेक्टर लज्जा करो तो सी केवे चाहिए डॉक्टर पाक जी डॉक्टर मत कहे तोर ब्लड प्रेसर होती आ 5 लोक शुणे डॉक्टर के कह ना अरे तुम तो डायबिटीज आ 5 लोक शुणे मत लाज लगे ये जो साइकोलोजी कारण जो साइलेस कारण ताकू देह खराब होला से डॉक्टर पाक आसने जो सीरीयस हो जबरदस्ती मेडिकल को आ जबरदस्त आनला बेलू स्वाभाविक जन डॉक्टर एत लास्ट एंड किसी ठीक कर बहुत जगह स्वर्गवास हो तेणु ये अकुहा कथा कहून जन लोकटा तार मनटा पड़ी तार कौन है जानिक ट्रिटमेंट करवा आ ताकू भल करवा एटा ही एक्चुअली ट्राइबल क्षेत्र आप बढ़ुचन जो भविष्य में यहाँ आपण मो बहुत बड़ अवदान हम जनजाति जदि यही नेचरटा आप शिखिए केमजोर तेणु आज ऋषिकांत हार्ट विषय आपण को ज्ञान दे जोटा कमी केउंझर बहुत कमी ताक धन्यवाद देवी मु किछि दिन आगु शुणुली ता विषय केबे देखाय नहीं ये मोर फास्ट देखा ता विषय शुणी यहाँ प्रोब्लेम अच्छी आमे भी चाहूँ जी मैडम जो कथा कहले महेंद्र बाबू कहले एक्चुअली आम प्रिय मुख्यमंत्री यूनिवर्सिटी है ड्रीम मोर भी आम दी जन दुई भाई ड्रीम आम आज को 24 वर्ष आगु आम चिंता कर मेडिकल कॉलेज हम किंतु भगवान इच्छा नाला तेणु आम 15 वर्ष है दुरिया थिलु ता भितर लास्ट एंडिंग रे हेछि आमे भाई में पुआ मान सहित भाई भाई मान सहित कथा होतलु मैडम को सेठी से आपण माने जीवा आगु हम ऑलरेडी मैडम नायक से काम सारी देले डिटेल विषय में कथा हेछि मो भी निश्चित रे इमीडिएट कहीं हमर इलेक्शन मुद्दा मोर सेटा जे मोर मेडिकल कॉलेज रे अपडेट हो मेडिकल कॉलेज मोर इच्छे लोक मैंने ट्रिटमेंट है जो आज कथा वर्ष दिया पड़े तापाई जहाँ रिक्वायर कहीं इलेक्शन मुद्दाटा यहाँ तेणु ये आधार जेहेतु आमर यहाँ ब्रेन चलती से 24 वर्ष आगे आम करूँ आ बहुत कथा हो मैडम सहित आशा रखी मन रे भावना नहीं आपण मैंने शिखतु केवल अंगटार ट्रिटमेंट करने शिखतु नहीं पूरा मनुष्यटा ट्रिटमेंट करने शिखतु बहुत धन्यवाद नमस्कार
Thank you, sir. I extend my heartfelt thanks to you for valuable presence and inspiring speech despite your busy schedule, sir. Now I would request Mahesh Mohanta, sir, for delivering the vote of thanks.
आजिर सम्मानित अतिथि श्रीजुक्त अनंत नायक एमपी केन्दुझर सांसद माननीय आमर प्रिंसिपल मैडम चिन्मयी मैडम आमर मेडिकल कॉलेज अध्यक्ष डॉक्टर महेंद्र नायक भाई एवं ऑल दी डिग्निटरीज of the dais आजिर एवं मोर सान भाई सदृश ऋषिकांत जो मत कहला जे आम गोटे प्रोग्रामटा करवा ईसीजी विषय मेडिकल कॉलेज रे तो आम जो चिन्मयी मैडम को अप्रोच कलु से मैडम कहले से दिन आमर दुईटा प्रोग्राम अच्छी ऑलरेडी तेणु पिला माने थकी जाइए पिला माने हयत इंटरेस्टेड हेबेनी एते कथा सकाळु संध्या पर्यंत लेक्चर शुणिबारे तेणु प्रथमे मु आमर मेडिकल स्टूडेंट मान को धन्यवाद जणेबी से धैर्यर सहित अपेक्षा कर शुणुंट लेक्चरर एवं धन्यवाद जणेबी आमर अनंत नायक एमपी तांकर बहुमूल्य समय देकी आम गहन किसी समय बीते चिन्मयी मैडम को धन्यवाद देवी आज ये प्रोग्राम पाई सम्मति प्रकाश कर एवं अन्य समस्त को धन्यवाद देवी आमर प्रेसिडेंट इंडियन मेडिकल एसोसिएशन रो डॉक्टर उमेश साहू अच्छा धन्यवाद देवी एवं समस्त सीनियर डाक्तर मान को डॉक्टर प्रभात हाटोई को विशेषकर धन्यवाद देवी से ये प्रोग्राम आयोजन करिवारे यथेष्ट साहाय्य करथिबारु एवं मिस्टर AR खान जे कि आमर प्रोग्राम रो कोऑर्डिनेट करचंती ताको मते बहुत धन्यवाद एति कही समस्त को पुणी थे धन्यवाद देकी मो मोर वक्तव्य समाप्त करछि थैंक यू
Thank you, sir. Now we will continue with the academic session to take it forward. So we would request Dr. Rishikant Mohanta sir to continue with the ECG session. Requesting guests on the stage, we can accompany you to the respective seats, sir. Thank you. To make the session more interactive, we would request Dr. Umesh Sahu sir, Senior Medicine, IMA President, to moderate the session. I request Dr. Umesh Sahu sir. Requesting sir. Now we will continue with the session.
Clinical academic session, ECG. It is very important test. Actually, lot of test has come out, like this echo, coronary CT, and isotope studies. All are expensive, and it is done in institutions. This ECG is a very handy test to immediately know what is the problem, immediately diagnose it and decide what to do. I think Dr. Rishikant will give justice to it and simplify it, and so that our beloved student can understand it and utilize. Thank you.
Thank you, sir. So once again continue our session. So specifically my topic will be all those slides, but important points I will recommend. So mo pilamanku request karibi ki most probably semane bahut jana ECG dekhi nothibe, but whenever they get any opportunity in the hospital, they just go through the ECG. You just go through the ECG, just look at the ECG. Then there are some points only. You just read it. Try to read it. Read any ECG you find on your table or with a patient. So just reading ECG step by step will take you ahead. So to start with, as I discussed, you also have already read, there are different waves, different intervals and different segments. So without wasting time, I will take very short time and directly I will go to how to interpret one ECG. So to start with, whenever you get any ECG from a patient or you find any ECG, you try to exercise one ECG each day, because this is the only diagnostic tool that can give 80 to 90% of disease diagnosis. Any cardiac condition or any abnormalities or any life-threatening condition, ECG can give maximum information to all of you. So to start with, as I discussed already, the ECG, how to calculate the rate, that is important. Step by step we'll go ahead. ଯେତେବେଳେ ଗୋଟେ ଆମେ ECG ଆମ ପାଖରେ ହାତକୁ ଆସିଲା, ଫାଷ୍ଟ ଇଜ ରେଟ୍ ଆମେ ଦେଖିବା ECG ରେ ଆମର ରେଟ୍ କ'ଣ ଅଛି, ପେସେଣ୍ଟର ହାର୍ଟ ରେଟ୍ କ'ଣ ଅଛି. ସୋ ହ୍ୱାଟ ଇଜ ଦ ଫର୍ମୁଲା, directly will go to interpretation. What is the formula? As I said कि गोटे ECG पेपर ଯେତେବେଳେ ଆମେ ମେସିନ ରୁ ବାହାରୁ comes at a speed of 25 mm per second. तो 25 mm माने गोटे ECG पेपर मु जोटा मु कहली आपन को देखाउतली, this is the ECG paper.
ସେଥିରେ କିଛି ଲାର୍ଜ ସ୍କୋୟାର ଥାଏ, କିଛି ସ୍ମଲ୍ ସ୍କୋୟାର ଥାଏ. ଗୋଟେ ଲାର୍ଜ ସ୍କୋୟାର 5 ଜାଗାର ସ୍ମଲ୍ ସ୍କୋୟାର ଥାଏ. ତ ଗୋଟେ ସ୍ମଲ୍ ସ୍କୋୟାର ହଉଛି 1 mm, ଗୋଟେ ଲାର୍ଜ ସ୍କୋୟାର ବି 5 ଟା. ତ ଆମେ ଯଦି ଦେଖିବା ଗୋଟେ ପେପର ସ୍ପିଡ 25 mm per second ରେ ପ୍ରିଣ୍ଟ ହଉଛି, ତାହେଲେ in 1 minute it will cover 1500 small squares. Okay, so 1500. Next we go to the RF interval. गोटे ECG रो टोटल ड्यूरेशन माने गोटे ECG जो प्रेशन होती RF interval गोटे पीक ऑफ R टू नेक्स्ट पीक ऑफ R, दैट वन साइकिल गोटे टाइप केतेटा स्मॉल स्क्वायर है. तो अगेन वी सी गोटे मिनिट रे टोटल सर्विस एटा कार्डियक साइकिल. तो आमी जदी गोटे RF इंटरवल को कैलकुलेट करू 1500 बाय RF इंटरवल, दैट इज रेट. सिंपल, दिस इज द फार्मूला. Simplest formula for you was 1500 by RF interval. If RF interval is same on the your heart rate is 100. If RF interval is 20, then heart rate is 75. If RF interval is 25, means 5 large squares or 25 small squares, then heart rate is 60. This is how we calculate the R to R is molecular rate, P to P is actual rate. यदि हमें इसी तरह एप्लीकेशंस का प्रॉब्लम है, A is different or Q is different and R is different. अभी हमें actual rate बाहर करेंगे P की interval and molecular rate करेंगे R. This is one example you can calculate. Next, if there is a big association, यदि P is different and QRS is different, the period will be separate, QRS rate will be separate. So for period, you calculate the PP interval, and for regular rate you calculate the RMS. यदि गोटे लोकर हार्ट रेट वृद्धि irregular अछि, then what to do? The number of RF intervals is 15 large squares into 20. This is simple formula. You have to remember. 15 का large square है कितना RF interval होगी multiply करके 20. This is simple. Next we will go to rate for it. Next हम देखते हैं और इधर resume. Okay. Resume calculate करेंगे हम step 1. Calculate rate and further. Next determine regularity. Then assess QS. PUF अच्छी की नहीं, sometimes PUF may be absent or it has a different morphology. Then determine the PR interval, then determine QS duration. This is a step by step. In a sinus regime, rate is normally 60-100. It is regular and PUF is normal. PR interval is 3 to 5 small squares. That is 120 to 200 milliseconds. And QRS duration is 0.04 to 0.12 seconds or 40 to 120 milliseconds. So any deviation from all of above is arrhythmia. Okay. Any deviation from above is sinus static area, sinus static area or an Next most important thing is what is the axis. First is red, then is rhythm, as I told, then is axis. Electrical axis of the heart, that is most important. Okay. This is the electrical axis. Normally it is between minus 30 to 90 degrees. The pink color, that is the normal electrical axis. Any deviation from minus 30 will be left axis deviation, and from plus 90 will be right axis deviation.
कि it will have vertically 2.5 mm and horizontally 2.5 mm. Okay, you just remember two things. Vertical 2.5, if it is taller than that, then it is right atrial enlargement. If it is more than 2.5 mm horizontally, then it is left atrial enlargement. Two things you have to remember. If it has taller than 2.5 and duration it is measured from beginning of the P wave to the tip of R wave, that is normally it should be the Q, but in practice
application of corrected QT interval by overall RI interval into corrected QT interval. So I'll quickly go show you some slides. This is a normal ECG showing sinus feeling. You can see this is sinus arrhythmia. Rate is usually 100 to 50 to 100. Reading is irregular, but this is sinus arrhythmia. This is what is sinus arrhythmia. PQRS remains same, but rate is more than 100. This is sinus tachycardia. Sinus bradycardia is less than 60. This is sinus arrest. P followed by QRS, but in between you don't find either P or QRS. So in that segment there is no electrical activity of that. So that is the sinus arrest. So one more important thing on arrhythmia aspect is atrial fibrillation, where P wave will be absent, and in that the atrial rate is normally 350 to 650. Ventricular rate may be low or fast. This is one ECG showing atrial fibrillation with rapid ventricular rate. So breathing is irregular, irregularly irregular. Any ECG showing irregularly irregular breathing diagnosis, fast diagnosis is atrial fibrillation. Breathing irregularly irregular, breathing is atrial fibrillation. This is same atrial fibrillation in slow ventricular rate. This is fast ventricular rate. This is slow ventricular rate. Here you can see the four atrial variants for the wave, that is total waves. So this is atrial flutter. Then coming to SBP, there is narrow pleural regular tachycardia, that is supraventricular tachycardia or SBP. Here in fast initial segment you can see the heart rate is more than 150 and followed by some normal disease. So this is called paroxysmal supraventricular tachycardia. Supraventricular means QRS will be narrow. Ventricular means QRS will be wide. So ventricular tachycardia, supraventricular tachycardia, they can see only QRS will be. So this is the ECG showing ventricular ectopic phase single EDCs. This is multifocal EDC because two ventricular ectopics are there, but they have different morphology. So this is two EDCs, but they are multifocal. This is coupled EDC, that is two ventricular ectopics, but morphology is same. So they are joined in here. Coupled. So
This is what is ventricular.
As compared to SVP, this is ventricular tachycardia. QRS is wide. So how to difference only three wide QRS tachycardia, that is ventricular tachycardia, rate more than 100, but QRS duration only more than 120. This is VT. So why VT is important? Because if it is untreated, it leads to decreased cardiac output, heart failure, cardiogenic shock, cerebral insufficiency, and coronary death. VT may change to death at any time, and it may lead to death. This is one ECG that is always called VT or oxidase speed on this. So morphology changes from time to time. Then one of the danger finding in ECG is ventricular fibrillation. This is the ECG, ventricular fibrillation. Repetitive series of chaotic waves originating in ventricle, no inflammatory of waves, PQRS cannot be recognized, gross irregularity of ventricular fibrillation cannot be detected, or any other reason except arrhythmia. If patient is conscious, rhythm is not. If patient is conscious, then rhythm is not here. This is here, and the ultimate it may lead to, if not intervene in time, it may cause assistance. So I try to complete all things in a very short time because we have another 2 speakers tomorrow. So thank you all. Last we will discuss whether we go ahead with other. So thank you.
Our next speaker is invited, Dr. Mahanta. Yeah. Actually, this is a very complex thing, ECG. A lot of time required to see it and interpret. As in a 15 minutes, it's very difficult to make you all understand. Please remember the terminology at least. In future, you will be requiring that. Dr. Mahanta.
Good evening, dignitaries and my dear friends. Today I am here for speaking something about ECG changes in myocardial infarction. First of all, this myocardial infarction is insufficiency of blood supply. I am not going to detail about this. In general definition, this statement usually electrolytes and typical characteristics. Especially occurs in working, particularly office, making me cold weather, emotional, inner irritations, and after taking cocaine. This is just type of Indian. Now coming to the myocardial injury, there is prolonged ischemia at least for 5 minutes. Common pattern when present in MI, reversible event is repeated early. Myocardial infarction that is rate of cardiac muscles generally caused by opening of one of the coronary arteries. That we have to locate now. Now coming to the ECG interpretation in myocardial infarction. Most important thing over here is SPG changes. SPG segment plus sleeve exchange. Abnormal voltage gradient because of the myocardial infarction there is instruction following instruction level. For the abnormal voltage gradient, this is active or passive depolarizing state. Change in situation of depolarization. Abnormality are associated with well-defined anatomy of physiological and pharmacological reasons. Active segment referred from PP or PR segment. Active depression is the risk from the PP segment or PR segment is below by. Now coming to the most important part. The same thing as you all this most important thing over here is dorsal pen. That is real, and 2, 3, 1, 2, 3 leaves. And in transverse pen, we go for the chest leaves. These are most important. Here we see I will see 3 things. This is real, and 2, 1, 2, 3. This is the heart position. This is 3 things usually you perform. Number 1 is this is lateral wall, this is inferior wall, and this is anterior lateral wall. So this one. So now go to this 10 picture of the heart now.
This is interval, this is interval, sector, this is left. So you can determine what is the inversion zone. And next is, this is from the test sheet, V1 to V6. Now coming to the interval will usually go for this active elevation in V1 to V6 according to set of phases. V1 and V2 is subtile V3, V4 is anti-region, and V5 is lateral region. Now we have just find out where is the location. This is vector spectrum. If the obstruction is just at the origin of the LAD, then you get symptom sequence will be different. Now, because current of injury is over here, so whenever there is current of injury is there, then this injury point will go from here to this point.
Current of injury that will be negative. So this is there will be ST depression in inferior leads. So you can see next. This is LAD occlusion proximal to both septal and perforator. You can get ST elevation in V1 to V4. Then ST depression in inferior leads 2, 3 and AVL. ST elevation in AVL and AVR. Just you can see from this location of injury. Next, this is from, we can pass this. Now, if a location, occlusion is distal part of LAD, that is distal to diagonal and perforator, then this is shows characteristic changes, because again current of injury will be somewhere occlusion over here. This is the LAD, so current of injury will go from here to here. So the ST elevation will occur in inferior leads and ST depression occur in AVR and AVL, including ST elevation in B1 to B5. This is. Sometimes you can see patient in the OPD or somewhere else, but patient is stable. This is the one reason. Why? Because there is obstruction is in the distal LAD. In distal LAD you get both ST elevation in inferior leads plus anterior leads. But patient will be stable because this is area of infraction is very low. You got this distal part. Now coming to the inferior infection. Inferior infection may be due to right coronary artery or LCX. Now you can see just this is right coronary artery. This is right ventricle and right side of coronary artery is this side. So the current of injury go from this to this side. And in LCX, this is LAD over the septum, and on the lateral wall, this is LCX. So current of injury go in this direction. So from this inferior leads 2, 3 and AVF. Current of injury toward the current of injury, you will get bigger ST elevation. So if you get ST elevation bigger in lead 3 more than lead 2, then it is ST elevation MI because of right coronary artery occlusion. Next, if you are getting a ST elevation more in lead 2 than lead 3, because current of injury L6 is more toward lead 2. So when you get a ST elevation more in lead 2 than lead 3, it is due to circumflex coronary artery. Again, in right coronary artery occlusion, patient will have hemodynamic disturbances because of hypotension. But in LCX, sometimes it is less because of this area of supply is less. Now this is the ECG finding.
In right coronary artery occlusion, ST elevation in lead 3 will be more than lead 2. This is, and ST depression in lead 1, because current of injury is towards down. So lead 1 is away, so you will get ST depression in lead 1. This is lead 1 ST depression, lead 3 more than lead 2. Next, in circumflex coronary occlusion, lead 2 ST elevation will be more than lead 3 plus because this current of injury is more aligned towards lead 1, so there will be no change in the lead 1. Lead 1 is same. If it is ST depression, lead 3 more than 2, it is RCA right coronary occlusion. If it is no changes in lead 1, lead 2 more than lead 3, ST elevation, that is LCX. This is some of the, just summarizing. Lead ST elevation, lead 3 more than 2 is RCA. B4R, if you are taking right side ECG lead, then you will get B4R ST elevation and T upright in the right side ECG. And in lead 1, ST depression. Same thing in LCX, lead 2 more than lead 3, B4R no elevation, T is negative, and lead 1 no depression. And one of the most important thing is sometimes patient is having chest pain severe, but there is no much of changes in the ECG. This is most of the due to posterior wall MI. There you can find this ECG ST depression in 1, 2 and 3. Just to reverse this 2, 3, 1, 2, 3, you can get typical picture of ST elevation, Q wave, ST elevation, T wave inversion. This is the feature of posterior wall MI. And sometimes you get isolated RBMI because of RB branch of the right side is blockage. There you may find minor changes in inferior leads, ST elevation in B1, B2, small collateral field with RCA on an occluded RB branch only, marked downward ST depression in 1, 2 and B4 to BC similar to severe proximal, small and collateral field RCA and an occluded RB branch. Now the most important of all of these things is diagnosis of left main occlusion. This is one of the very important and you should be very cautious about this. Severe hemodynamic deterioration in acute complete occlusion. Because most of the time this is subtotal occlusion. Patient is alive, so it is before patient is before you. If it is complete occlusion, patient will die within minutes. So most of the time it is subtotal occlusion seen or with collateral filling from the RCA presenting with unstable angina in case of late case. ST vector in frontal plane point to AVR and horizontal plane it is B1. This is in left main occlusion, you will get two things. ST elevation, because it is proximal left main is the origin of the left main, so ST vector will move towards AVR and B1. These two things you have to look at. Whenever you find ST depression in B2, B3 and B up to B6, but patient is hemodynamically unstable, always look for ST changes in AVR and B1. If you are getting ST elevation in AVR and B1, always think it is left main. This is small thing. You can sometimes get in old LBB, sometimes you get acute MI. You have to just measure two things, ST elevation of more than 5 MI with negative QRS and ST elevation of more than 1 mm in positive QRS. This is just like this. If interval MI with LBB, this ST elevation is in chest leads is more than 5 mm. LBB with right artery occlusion, you will get ST elevation in inferior leads with LBB in the lateral leads. There is no changes in ST heights of the LBBs. And this is one inferior wall MI with CHB. There is no coordination between P and QRS complexes. In conclusion, it is a reliable in complementary localization and level of block and extent of MI, help in anticipating complications and anatomical variation and previous coronary events will modify the correlation. Treatment nowadays, primary PCI is the most important thing whenever it is possible. If not, go for thrombolysis. Again, invasive is always better than conservative. Conservative is early procedure, now we should go for invasive. Now, thrombolysis therapy, you can go for anywhere in the remote area also, you can go for thrombolysis therapy. It is just like a pitch hitting. If it is clicks, then you are success. Around 60, in one set of 70 to 80% cases are success. Last of this, antiplatelets. And this is just like antiplatelet therapy, like Tendulkar. Keep on going, the opener play, and beta blocker, as it's carry over, slows down the game but keeps the wicket intact. And this ACE inhibitor, Captain Cool, as you know, doesn't let the response to build, and statins keep on coming until it cleans it off. Yes, thank you.
Thank you, Dr. Dilip Mahanta, cardiologist. And actually I thank him, he has given this cricket example for a different treatment of the MI. Thank you, sir. I now invite Professor Thatoi, who is our teacher, HOD Medicine of this medical college. Actually, the discussion our cardiologist delivered is something higher level. I think our teacher, Professor Thatoi, knows what is to be told to his students, and he will speak little more fundamental and what is required for MBBS students. I remember when I was appearing in my final MBBS examination, Professor Akulalan Sadangi was there, medicine professor, sir must be knowing. In the exam, I had a cardiology case having AI. You know AI? Outing incompetence case. He asked one question to me. Can you differentiate in the ECG, AI and AS? I humbly told, no, I don't know. He told, I would have given you honors if you could have told the difference. So it is not a simple subject. It is a difficult subject. By practicing, you will develop the skill of interpreting ECG. Dr. Professor Thatoi, please.
Thank you, sir, for your kind word. Respected delegates, my dear students. So, we will not waste much time because ECG for the beginners is a really, I am reading ECG from last 25 or 30 years from my MBBS career. So, you read and you forget. Again you read, again you forget. So all those things happens, it's a matter of things. So my previous speakers, they have, Dr. Rusikant has nicely pointed out the normal ECG, but it will be better if you people have all those things handy in your mobile phone. That will be better if somehow we can provide you better. Second is, interpreting acute mitral infarction by Dr. Dilip Mahanta. That is very good, but for the beginners, it looks very difficult to digest, maximum of you, unless until you are very expert. So my point is critical care ECG. So what is critical care ECG, I will take. So it happens in critically ill patients, particularly electrolyte imbalance, potassium, calcium, magnesium, maybe in hypothermia, some of the drugs also. You know this. Now I will ask, what is this? For the students, our senior students, and for the first year students also. So what is this diagram? You must have read it from physiology. What is this? Action potentials, cardiac action potential. Very good. So, and this is one ECG graph, ECG picture from tracing. So, ECG, forget, is nothing but it is summation from the very basic. It is summation of all action potentials recorded over by the some leads. It may be chest lead, it may be limb lead. Okay, summation of action potentials. Summation of action potentials. They are recorded over body surface. Is otherwise known as electrocardiogram. Very simple, electrocardiogram. So, for all living cells, they are having action potentials. Yes or no? Action potentials are regulated by exchange of ions. Very good. This is fundamental. Exchange of ions. So by how human beings or terrestrial animals are different from aquatic animals. From the beginning, we have derivated from amoeba cell. You will go scientifically. So in amoeba or aquatic things, so inside the cell, which ion is much more? In terrestrial part, in human beings, in each cell, see, potassium is abundant inside the cell, and outside the cell, sodium. So they cannot cross, but there are some active, gates. Okay, so they cross each other. Equal amount of potassium goes in, and equal amounts of sodium goes out. So like that, to create the action potential. Yes or no? So all these action potential recorded over the limb surface is ECG. So if I will ask one by one, for this phase 0, which ion is responsible? Very good, smart answer. So you have read very nicely, physiology madam has taught you. So sodium ions, it goes much more in the speed that recorded are, this is the phase 0, which is recorded in ECG or QRS. It's a rough correlation. Okay. Then, and phase 1 is what? Phase 1 is, it is better because the lead goes up. Okay, when sodium gets closes, it goes up, little bit up, that is recorded as 1. But for phase 2 is calcium, slow calcium entry. Slow calcium entry. Slow calcium entry into the cell. Slow calcium entry inside the cell. The calcium goes from outside to inside. So that is recorded as phase 2. Yes or no? Any doubt? And what is phase 3? Closure of now, phase 0 closure of sodium. When starts, the stimulate is bit high. There is controversy. Stimulate is bit high, but stage 2 is because of potassium, because of calcium entry, slow calcium entry. And phase 3 is because of potassium going out or in. Potassium goes out. Okay. So that causes the potential to come down, and here reversal automatically happens. Clear? So that is why if the calcium channel or this this segment, this summation of these are recorded as ST segment. So anything wrong in calcium will be shown at the wrong in ST segment. It may be much more calcium, hypercalcemia. It may be less calcium, hypocalcemia. So change will come at ST segment. And if what is this? Potassium. Potassium going out. If the outer surface has much more potassium, so that will be reflected at T wave. This potassium roughly correlates this T wave. With this basic, you will proceed. So if there is much more potassium hyperkalemia, you will look this T has some change. It may be tall tented T. Okay. If you have less potassium, normal potassium level is 5.5. If it goes 5.5 above, ECG change may not happen, but if it goes more than 6, 6.5 or 7, then you will get the change over T wave. Okay, you will pick it up from the ECG. If potassium goes down less than 3, it may be 2.5, it may be 1.5, or it may be nearing to 1. So you will get this. But why ECG change doesn't happen in sodium changes? You can ask me. Okay, why there is no ECG change, nowhere recorded ECG changes in hypernatremia or hyponatremia. So for that, the person might have been died, because normal sodium value is 135 to 145. If it goes more than 145, then it is hypernatremia. If it goes less than 135, so hyponatremia. And clinically we get patient symptomatic if it comes less than 130 milliequivalent per liter of sodium, almost up to 125, or in chronic cases less than 120, then we get symptomatic patients of hyponatremia, loss of less sodium symptoms. Okay, but in hyponatremia, with that the sufficient amount of sodium is there to maintain this QRS complex. So in hyponatremia or hypernatremia, body has sufficient amount of sodium so that the ECG changes doesn't happen. If the ECG changes will happen in hyponatremia, the sodium might have come to less than 30 or less than 40. By that time, person will die. So that is why its sodium changes, no ECG changes have been recorded. But for little potassium changes, because potassium value is 4.5 something, so little up and down ECG changes will come. Like that, hyperkalemia calcium level is something around 3. If it goes more than 3, then 4 or 5, or it comes to hypocalcemia of 2 or 1.5, then we will get ECG changes. So with this basic, we will start. With hypokalemia, one case. So in hypokalemia, when ECG features of hypocalcemia, when potassium goes less than 3. So ECG change will not come in 3 around, it will come to, if come to less than 2.7, then ECG changes will come. That is increased P wave amplitude, prolonged PR interval, but the most important is we say widespread ST depression and T wave flattening or inversion. I would say potassium is responsible for T waves. So in T wave flattening or inversion, you suspect of maybe patient is having hypokalemia. Prominent U wave will appear. So PQRST you will get here somewhere. This is T, another wave is there, it's called U wave. So appearance U wave is also physiological in some cases, but with this scenario U wave, you certain that the patient is having hypokalemia. The PR segment is going down, somebody has pushed the P down. So hypokalemia creates the illusion that the T wave is pushed down with resultant T wave flattening or inversion, ST depression and prominent U waves. But in hyperkalemia, just opposite. You just hypokalemia, T wave inversion, ST depression, prominent U wave. For hyperkalemia, the T wave is pulled upwards, so tall tenting T here, creating tall tented T waves and stretching the remainder of the ECG to cause P wave flattening, PR prolongation, QRS widening. So ST-T changes happen with the change in potassium values. Hypokalemia causes myocardial hyperexcitability with the potential to develop re-entrant arrhythmias. You know, this is the degree of hypokalemia. If potassium from 3 to 3.4, mild hypokalemia, where ECG changes may not be. You cannot get here ECG changes. But for moderate, once potassium value comes between 2.5 to 2.9, that is moderate or severe less than 2.4, then you will get often associated you will get the ECG changes. There is the thing, potassium and magnesium, they go side by side. Many of the time, hypokalemia is associated with hypomagnesemia also, which increases the risk of malignant ventral arrhythmia, particularly toxoid spondylitis, I will tell later. Check both potassium and magnesium levels at any point patient with arrhythmia. Replace potassium to 0.4 replace potassium so that the blood level comes between 4 milliequivalent per liter or between 4 to 5. And magnesium should be more than 1 milliequivalent per liter to stabilize the myocardium and protect against arrhythmia. This is the standard practice in coronary care unit and ICUs. So one ECG of hypokalemia, that is widespread ST, and second, where you will get your B wave better in lead 2 or in V1, V2. So B wave is because of which activities? Atrial. So in the heart, atrium remains upper side. So and lead 2 and chest lead V1, V2 are nearer to atrium. So for atrial activities, look at V1, V2 or limb lead 2. Okay. So this is the basic. So prominent here, widespread STT depression, T wave inversion, prominent U waves and long QU interval. You look at this long QU. So QRS interval, Q starts from here to UR. This is a long QU interval, and here is one U wave. This is T wave followed by another U wave here. Just T U have missed. So there is a long interval. And coming to hyperkalemia, it defined as serum potassium more than 5.5. ECG changes do not manifest until there is moderate degree. If hyperkalemia goes more than 6, then ECG manifestation can be detected. The earliest manifestation hyperkalemia is increase in T wave amplitude. I told you potassium is the normal part. Potassium is responsible for this T wave. ECG features of hyperkalemia: peak T waves, T wave widening, flattening, pair prolongation, bradyarrhythmias. There is sinus bradycardia, high grade AV block with slow junctional and ventricular escape regions. It's not required for you. With worsening of hyperkalemia, if the level goes more than 9, it is very difficult to thrive. Development of sine wave appearance, preterminal arrhythmia. I will tell you what is sine wave appearance. Ventricular fibrillation, pulseless electrical activity, the bizarre wide complex rhythm, and ultimately go to asystole. So this is one. Yeah. So this is for prolonged PR interval, broad PRA QRS complexes, peak T waves. So with looking at these T waves, you suspect that the person is having some gross change in potassium level. Long PR, wide bizarre QRS. This is SAM. Slow nothing, intraventricular tall big waves. This is called sine wave appearance with severe hyperkalemia. If level goes more than 9, you look at this. This wave, sine wave. Okay. Dangerous hyperkalemia, and the treatment immediate ECG gives you, it just guides you. Immediately you do the potassium value and send the patient for hemodialysis. This is the treatment of choice. In 9 level, sine wave, don't wait for giving some, potassium, lowering drugs, nebulization, salbutamol, giving dialysis. It will not work. Go for hemodialysis first. Then, so this is huge peak T wave, sine wave appearance, severe hyperkalemia, and hypercalcemia. But this is normal ECG. This is hypercalcemia, short ST segment. This is hypercalcemia, long ST segment. So the main ECG abnormality seen in hypercalcemia is shortening of QR interval. In severe hypocalcemia, option waves or J waves may be seen. Ventricular irritability, ventricular fibrillation, arrest has been reported with extreme hypercalcemia. Hypercalcemia, I go fast. Hypercalcemia, fatigue mass, fatigue of the QT interval. Once ST interval shortens, so ultimately the QT interval shortens. So once QT interval shortens, so I will tell you so what is R on T phenomenon little. So Sam, we are coming to hypocalcemia. The QT interval, hypocalcemia, both hypocalcemia, look at this broadening, QT prolongation, serum over calculation. Hypocalcemia, QT prolongation in patients with Diger syndrome, calcium of 1.32 have severe hypocalcemia. So because of this ST prolongation, so QT ultimately goes prolonged. So you people have reduced why? So hypomagnesemia also same. Prolonged period. See, chances of hypomagnesemia are similar with hypokalemia. Prolonged PR interval, prolonged QT interval, atrial ventricular ectopic, predisposed to ventricular tachycardia, Torsades point is. So why Torsades point is comes, I will tell you. Before, so this is the QT interval. You will calculate what is the QT interval. I think Dr. Singham has nicely explained everything. So my point is, coming to our basic thing. So with this basic, you will get all the answers. So in this normal action potential, the first two-thirds of the action potential is known as, anybody? Two-thirds physiology, two-thirds and one-third. Absolute, very good. Absolute refractory period. So absolute refractory period means it comes almost up to this level. So first two-thirds of the action potential, yes or no? First two-thirds or one-third or one-fourth? First two-thirds. From here it begins up to here is absolute refractory period, and with this period if you will stimulate, it will not get any response. Yes or no? And after that it comes up to this phase is relative refractory period, RRP, relative refractory period. If the relative refractory period is there, if you will stimulate with a big impulse, more than that impulse which the action potential, the myocyte is getting, then it will fire, it will receive, yes or no? And after that, here, absolute refractory period, relative refractory period, and there is a little window here. What is known as? Anybody? S and P. Supra, what is the name? Supranormal phase. What was it? Supranormal phase. Supranormal phase is a phase where you just any small activity, choto action potential, if touches here, then there is one action potential. Yes or no? Okay. So now there are so many drugs which can interfere with this potassium, like potassium channel blockers, potassium channel openers, calcium channel blockers, calcium channel openers, sodium channel antiarrhythmic drugs. Antiarrhythmic drugs are pro-arrhythmic also. So there are other drugs like combination of artesunate and quinine. Quinine is one of the notorious drugs. Artesunate and quinine, that is now completely banned. If you combine that, so it causes prolongation of there is some interference with the electrical activities, it will prolong the QT interval. So Q starts from here and up to here is QT. Okay. So if it prolongs, some drugs are there, if you get little prolongation of QT interval, so the next action potential falls over the supranormal phase. Clear? Ebe bujh palan nahi? Suppose it is the body re 72, normal heart rate is 72. or 60 to 90. Let it be 72. 72 heart rate rhythm charge. तमें कौन टाइम बेसी है अपनी 250 कारण बॉडी एक्सरसाइज करती जे नेक्स्ट एक्शन पोटेंशियल आसीबो एई जगह रे पड़िबो जदि से एक्शन पोटेंशियल रा इफ दैट इज फॉल्स ओवर दिस सुप्रानॉर्मल फेज यस साइड टू फायर इज नहीं yes or no. So what nature if you will give some drug or some other drugs which can prolong this QT, that means you are allowing body to fall on one action potential over supranormal phase. So that is the basic of torsades dispondis or arrhythmia or things. So with that we will come to our QT interval. Nicely pointed out. Corrected QT interval formula, this is budget formula, she has pointed out normal QTC interval. So what causes the prolonged QT interval so that arrhythmia will happen. So this is, there are so many causes of QT prolongation, hypokalemia, hypomagnesemia, particularly hypomagnesemia, that causes QT interval to prolong so that the next action potential falls over the supranormal phase or relative refractory period causing arrhythmia. So that causes the desired type of torsades dispondis. Hypocalcemia, hypothermia, myocardial ischemia, resuscitation of post cardiac arrest, raised intracranial pressure, congenital long disease, one of the dangerous syndrome, Buguda's syndrome, congenital long QT syndrome beyond 10 years or 12 years. Because with that, dangerous arrhythmia, the person dies. Long QT interval from the beginning. So that means their supranormal, he is exposed to their supranormal phase anytime one action potential comes and falls over the supranormal phase. Congenital long QT syndrome, medications and drugs, particularly quinine and combination of quinine and artesunate, antimalarial drugs. So I think this is ECG 20. Apparent QT interval, this is not required for you. So short QT interval, hypercalcemia, long QT, now short QT, congenital short QT syndrome, dioxin effect, these are things. Just you remember, thank you very much, because the basic is way from action potential, then you can understand ECG. Thank you. Sir.
Thank you, Professor Thatoi. He depicted action potential and this of single myocardial cell and the actual action potential in the heart.
Yes.
Actually, heart is a collective of myofibrils. There is a systemic contraction because the contraction starts from the apex, so that blood will be pushed to the aorta and to the pulmonary arteries. So there is a conductive system and the impulse arises from SA node, then AB node, delay and conducts throughout the myocardium. So you will understand it better once you go through it and see the patient and diagnose it. At the end, I thank Dr. Rishikant Mahanta who arranged this and also described everything, and Dr. Dilip Kumar Mahanta, our cardiologist here at Keonjhar, and finally Professor Thatoi, your medicine professor, who understands what you need it and he described it before you. Thank you all the audience and thank you my dear students.
So we are at the end of ECG workshop. So this is the fourth time, this is the fourth year I have been conducting the ECG workshop. Last year I conducted at Swasti Premium and 4 to 5 medical college students like SCB, Barampur, Baleswar, and even some students from Bolangir joined there. So they already requested me to conduct such sessions every year. So this time I conducted it here because as you know, this is my favorite place, my native place. So before concluding the session, I will thank all the students especially speakers Dr. Dilip sir and Prabhat Adai sir, and our moderator Umesh Saud sir, and Superintendent Mahendra sir and Chinmay madam, our Dean of the institution. So before concluding, just a small remark and a small suggestion and a small advice for my students. One very small, that is my personal experience, I want to share with you. Once we are into the medical science, our last पर्यंत केबे पढ़ा शेष होबो नाही कि चलीथिबो. आम लाइफ रे बहुत टीचर्स आसीबे, बहुत सीनियर्स आसीबे, किंतु हमको समस्त को शिक्षा पड़ियो. पाठ तो बही रे अछि, यूट्यूब रे अछि, गूगल रे अछि, सब जिनस अवेलेबल गूगल रे आजिकली अवेलेबल, क्लाउड रे सब जिनस अवेलेबल. किंतु गोटे जिनस मोर पर्सनल एक्सपीरियंस, ईसीजी गूगल रीड कर पारिबो नाही, कले मध्ये से ट्रीटमेंट कर पारिबो नाही. डायग्नोसिस करिया पई गोटे क्लिनिकल अक्युमेंट दरकार. ड्रग नेम, ड्रग क्लासिफिकेशन, ड्रग डोजिंग, pathological findings, clinical features, everything you will get in cloud, except one thing, that is clinical experience. Because cloud cannot hear the heart sound for you. एटा को निज को सुनिया पड़े. आमे परकशन करी कि कदर निमोथोराक्स अछि के हाइड्रोथोराक्स अछि, हमको जानिया पड़े. आमे देखु गोटे एसाइटिस को डायग्नोस करिया कथा. जेवीपी रेज अछि कि नो अछि गूगल देखि कहि परियो नै आपण. गोटे मर्मर भी गूगल देखि कहि परियो नै. एंड हमको सब बेले जे गोटे हायर मेडिकल सेंटर काम करिया पड़ियो सेंटर किछ न. हमको रूरल सर्विस भी करिया पड़ियो, निज घरे भी करिया पड़ियो. वी हैव टू ट्रीट आवर patients, we have to treat our friends, we have to treat our family members, we have to treat ourselves also. Because one of a cardiology professor who was my teacher, he had some sort of discomfort in the chest. He ignored कि मुझे gas है जाइतो, but after 12 hours when ECG was done, he was diagnosed myocardial infarction and PTC was done. So एमिति मोर गोटे जिनस मेसेज देबा पे मु चाहूची. हमको समस्त पाखर किछि शिखिबार अछि. सब रास्ता रे हम जोठी गले मध्ये शिखिबा पड़ियो, स्टार्टिंग फ्रॉम आवर फ्रेंड्स टू सीनियर्स टू टीचर्स, इवन मैक्सिमम शिखिबार अछि पेशेंट कथा. मोर छोटो एग्जांपल कहबी. हमर when I joined as intern in the second unit of medicine at SB Medical College, Prabhat sir joined as lecturer. On the same week, Muta Purguru, probably I had completed my duty in surgery ward. SPM duty मध्ये मु सारिथिले. तो both of us were on medicine OPD. और आज पर्यंत medicine रे I am lucky enough to get so many best teachers of medicine. जेतन पीजी करथली डॉक्टर विद्युत सर, डॉक्टर सीवीके महांती, डॉक्टर हमर मनोज महापात्र, दिलीप पटेल, समस्त काशीनाथ पढ़िया सर, एलके दास सर, they were my teachers. All the professor best teachers मु सेतर पाइथि. But in 1 month of my medicine internship, मु थापल सर को पाखर गोटे जिंस सिखिले जोटा आज पर्यंत बहुत हमर सो दैट आई वांट टू शेयर. आमे गोटे ओपीडी रे बसलु, मेडिसिन ओपीडी, गोटे पेशेंट केम विथ एनीमिया. डायग्नोसिस हला एनीमिया, ही टोल्ड मी टू राइट समथिंग. मु लिखि देली गोटे अल्बेंडाजोल एंड गोटे आयरन प्रिपरेशन. सर मो प्रिस्क्रिप्शन ने काट देले. आयरन प्रिपरेशन गोटे मु कोन लिखि देली, सेटा काटी देले, सेट लिखि देले ऑट्रेन. गोटे अल्बेंडाजोल लिखि देली, ताको काटी देले, लिखि देले जेंटल. मोर ब्रांड नेम एबी मने अछि, सर पर लिखि देले. तांकर एक्सप्लेनेशन थला, आई वाज देयर विथ 2 of my friends. से कोले तो गोटे मेडिकल कॉलेज रो प्रेसक्रिप्शन लेखुछ, यू आर इन ए लर्निंग फेज, यू शुड ऑलवेज राइट द बेस्ट ब्रांड अवेलेबल इन द मार्केट. एंड दैट थिंग आज पर्यंत इन लास्ट 20 years of my clinical practice. Gote jinso mu actually follow karuchi. I never go to any branch that is below top 10 companies of India. Those insurance I will insist to my students to follow some learn some good experiences from your seniors. ବହିରେ ତ ସବୁ ଅଛି, ଗୁଗୁଲରେ ସବୁ ଅଛି, ପାଠ ସମସ୍ତେ କରୁଛନ୍ତି, ସମସ୍ତେ ପାସ୍ କରୁଛନ୍ତି, ବଟ୍ ଭଲ ଡକ୍ଟର ହେବା ପାଇଁ ଏଇସବୁ ବହୁତ ସମୟ ଦରକାର ପଡ଼େ ନାହିଁ। କେତେ ଆଉ ଗୋଟେ ଏକ୍ଜାମ୍ପଲ୍ କହିବି, ମୁଁ ଜଷ୍ଟ ସମଟାଇମ୍ସ ଆନାଲାଇଜ୍, ମୁଁ କଟକରେ ରୁହେ, ସମଟାଇମ୍ସ ଆନାଲାଇଜ୍ ମୋର ଘର ପଛ ଜଷ୍ଟ 500 ମିଟରରେ ରହନ୍ତି ପୂର୍ଣ୍ଣଚନ୍ଦ୍ର ମହାପାତ୍ର ସାର୍, one of the India's famous gynecologist. My professor C.V.K. Manthi sir, my professor Vidudhar sir. You will not find any difference in their precision, in their diagnosis. People remember him, praise him like God. Only one thing. जो मुझे एक्चुअली करती किसी डिफरेंस नहीं. You will write also same medicine, they will write also same medicine. You will write same diagnose same thing, they will also diagnose. Only what is the difference? Only the behavior, nothing else. This is what is my experience. I am very बहुत close relations. It's no difference. Only their attitude and behavior toward the patient. That is most important. That is the only key of healing to the patient. Thank you once again. So we have arranged a dinner at cafeteria. Let's join there. Thank you.